All right, are there any questions from the stuff we covered last time regarding kind of the basics of kinetics, talking about absorption and distribution and all that good stuff? All right. So we're talking about clearance. And again, what is clearance? Yeah, so how are we actually getting rid of the drug, and what are some ways we can get rid of the drug? Renal, liver. Hmm? Yeah, through the body. Yeah, so when you say like excretion through the liver, typically you're thinking like through the biliary tract and excreting that through the feces. Those are the main ones. In some cases you may see some elimination of drug through the lungs and rare ones, but those are the two big ones you're going to see there. We were talking about creatinine clearance, and again, we use creatinine. We use the serum level of creatinine as a surrogate for how well you should be filtering creatinine from the blood, essentially in the kidneys, right? So, for instance, if I have someone who's building up a lot of creatinine, that should tell me what about kidney function. It's probably not as good as it would be otherwise, right? So, for instance, I don't know if I mentioned this, but I had a really sick patient that came into the hospital there last week or the week before. Normally you think like a typical adult patient, a creatinine of like 0.8 to 1.2, usually is pretty normal for most of the individuals. This patient was in acute renal failure. Her creatinine was like 5. Okay. Yes, sir.
Generally, like if they have a muscle breakdown, like they ran like marathon because of that, high level.
Sure, yeah, and the high protein intake, muscle breakdown, all of those things could definitely lead to increased creatinine for sure. This patient, though, her issue was mainly that overwhelming sepsis leading to acute kidney injury, and so she was just holding on to all this creatinine. So again, it goes to show you that if you hold on to more creatinine, that is indicative of poor kidney function, which is why we use the serum creatinine as a surrogate for how well the kidneys are functioning. So I mentioned we use that to calculate creatinine clearance. Remember how age is a factor there. Remember weight of the patient. Remember the actual creatinine value itself all gets factored in. It's good to know how each of those factors will change the creatinine clearance overall, right? So I have an older patients, you think their kidney function is better or worse than the younger one? Probably worse, right? So you'd expect that as a patient gets older, that would also drop down their creatinine clearance as well. So typically, when you're looking at, say like a male versus a female patient, average is about 120 mLs a minute. So anywhere between like 95 to 120, usually pretty normal as far as creatinine clearance goes. Again, this is just a surrogate for what the GFR actually is. It's not perfect, but we use it most frequently for drug dosing purposes, right? So, for instance, when you're looking up on your homework assignments, if you had for instance, vancomycin or something. I don't know if I give that to anyone, but if you're looking at vancomycin, you'll see your normal dosing for like an adult patient, and then you see dosing if their creatinine clearance is say 60 to 90 or 30 to 60 or 15 to 30. And by looking at that, you can see how the dosing changes pretty dramatically as far as the dose you're going to give, or potentially how often you actually give the drug. Maybe because I'm clearing it slower, then I'm going to have to give it less frequently. Otherwise, those levels are going to build up and potentially get toxic, as we'll see here in a minute. So looking at the clearance and the volume of distribution, what is volume of distribution? Oh, yes.
My question was the same concept apply to GFR? Are we looking at that as well when we consider
Yes, yeah. So like I said, creatinine clearance is basically our way of trying to guess what the GFR actually is, right? Because anyone know like the gold standard way of actually determining GFR? You could do like a 24-hour creatinine collection, so you could actually have the patient go around carrying a urinal and collecting all the urine for a full 24 hours. Not super practical, right? No one wants to carry around a big bucket of their pee all day. I don't, unless like I'm on vacation or something. But but there's that. You could either give them a product called inulin, something that does not get either secreted or reabsorbed from the kidneys. That is another way you could potentially collect that. Again, not practical. We know based on studies that we have seen that, okay, well, if we just look at the serum value, this is good enough to kind of get us an idea of what the actual kidneys are doing from an actual GFR standpoint. So again, creatinine clearance is not synonymous with GFR, but it is our way of kind of informing what GFR actually is, right?
This might be a silly question, but why, when patients are given contrast, they have to measure the UN of the clearance?
So contrast is important because, and when I say contrast, what I mean? Yeah, so we're usually like things for imaging, right? So things are going to be radio opaque or something. If you were doing like a CT scan or something like that, something that would show up, visibly white, based on a CT scan. So you can look for like brain bleeds and all kinds of things. The big thing there is that you can see that, especially certain varieties of contrast, they can be very, very hard on the kidneys, right? So they're very osmolar. They can cause a lot of damage done to the kidneys, and so you have to make sure they have good clearance to begin with, and oftentimes you're often giving those patients a lot of fluid to try to kind of tank up the intravascular space. That way they can kind of help to flood the kidneys, essentially, to flush all that stuff out. Because if you end up holding on to it, it can cause further kidney damage. And then that, and again, when you have a patient like that in the hospital, they're coming in for, say, a DVT or something, right? You're trying to image them for, and all of a sudden you get them acute kidney injury because you gave them contrast and didn't look at their creatinine before. Do you think the insurances want to pay for that? Heck no, they don't want to pay for something that you did to the patient, right? So now that's on the hospital to cover. So those are, and again, it's good for the patient, right? That's why we check that sort of stuff. So anyway, so again, looking at the clearance, and we said, what is volume of distribution? Yeah, how extensively the drug is going to partition out into the tissues there. So again, if it's partitioned into the tissues, if it's not in the bloodstream, can it be cleared from the body? No, it has to get back into the bloodstream because, again, it has to either get to the liver or get to the kidneys in order to be eliminated. So things with higher volumes of distribution, things that like to partition way far out into the tissue, will stay there for a while. And that's why I was talking about with like THC. If you have a really heavy user, a lot of adipose tissue, they can be positive for weeks, as opposed to someone who did not have that extensive volume of distribution. They may only be positive for a couple of days, depending on use. So that goes to show you that there's an equilibrium between what's in the bloodstream and what's out in the tissue. And as I clear what's in the blood, you'll have that drug leach out from the tissue back into the bloodstream, and again, to get that equilibrium there. Okay, so looking at that, we can look at clearance, which is how fast we're actually getting rid of drug from the body, and we're looking at volume of distribution, which is how distributed out it is in the tissue. That will inform what the half-life is. And what is half-life? Yeah, how long to get 50% of that drug gone, essentially, right? So again, if you imagine if I have less clearance, what is that going to do to my half-life? Yeah, so this one's going to be kind of, it's going to be inversely proportional, right? So again, the slower the clearance is, the longer the half-life is going to get, right? So you're going to see that the drug sticks around for longer. If I have something that has a lot larger volume of distribution, what do you think that does to half-life? It should increase, right? Because again, I have less drug getting into the bloodstream to be eliminated, right? So because it's all out in the tissue. So you can see that if you were to have modifications of this, where maybe, for instance, I have a really hydrophilic drug, a drug really likes to be in the water, and I have someone who has a significant amount of edema building up, that drug will partition out to there. If it's not in the bloodstream to get filtered by the kidneys, it's not going to get eliminated, right? So you can see how that can have an effect on increasing the half-life. And again, if the kidneys just aren't functioning very well, as that patient I was talking about, her creatinine was 5. Her creatinine clearance is basically 0 at that point, or very close to 0. She was not going to filter anything. So the half-life would be kind of indefinite in some cases at that point, right? So anyone know what you do with a patient like that? His kidneys are just like totally shut down? Dialysis, yeah. So we ended up putting her on something we call continuous renal replacement therapy, which is basically like, with dialysis, usually it's like an intermittent sort of thing where you do like 4 hours at a time. This was like a continuous sort of thing where you actually, all the blood's continuously be pumped out, filtered, and pumped back into the patient. Right? Anyway, so again, this is going to help us by knowing the half-life, by knowing the changes in distribution and clearance. Will tell us what the steady state plasma level is, right? And we talked about steady state before. We'll talk about it now, but. And one of the other big concepts we're going to get into before we get to steady state is going to be the concept of first order versus zero order elimination. And what I'll tell you now is that the majority of drugs you're going to talk about, and again, when we're talking about kinetics in general, we're talking about first order elimination, right? So unless I say otherwise, it's going to be first order. This basically means that it's going to be eliminating the same percentage of drug per unit of time, right? So again, maybe 15% every hour per hour, right? So again, have 15% eliminated the first hour, 15% eliminated the second hour. So that will show you that as you have higher levels in the beginning, you're metabolizing more drug per hour than you would be at the very end, right? So if you have a very small amount in the body, it's still 15%. Again, it gets incrementally smaller as you go on. I'll show you some graphs that'll make that more clear. So again, the higher the concentration, the more metabolism that's happening, because the more drug that's there to either get filtered by the kidneys or interact with enzymes in the liver, whatever it happens to be. The flip side of that is going to be zero order kinetics, where basically you're eliminating the same amount of drug per unit of time. So for instance, I'd use ethanol as a good example of this. We use this in the ER pretty frequently because we can actually estimate if a person comes in, and what the legal limit for alcohol is. Yeah, 0.08 or 80 milligrams per deciliter is another way to rearrange that. But so if I have someone who comes in and they're drunk as a skunk and they have a level of like say 160, so they're twice the legal limit, I can estimate how long it will take for them to become legally sober, right? So less than 80 at that point. Based on the fact that it's a zero order kinetics, I know they're roughly going to be metabolizing 20 milligrams per deciliter per hour. It doesn't matter if they have a level of 500, it doesn't matter if they have a level of 100, the amount of drug per unit of time does not change. It's always going to be constant because you've saturated those enzymes in the liver or wherever it happens to be, and you can't really go any faster than that, okay? So we'll look at how it shows up on a graph. One of these is going to be more of a curved line, one's going to be a very straight line, as we'll see. So looking at the zero order, Notice here that the proportion of drug, the amount of drug that actually gets eliminated per unit of time never changes, right? So again, it's always going to be the same amount of drug per unit of time. However, with the first order sort of kinetics here, the higher the concentration is initially, you're going to see a much steeper curve at the top because I'm metabolizing the same percentage of drug, right? It just happens to be a lot more because the total body amount's higher, as opposed to when I get to the very bottom here. Notice there's very little drug left. Still the same proportion, but it's going to be a lot more shallow of a curve at this point. Okay, kind of makes sense? So again, most drugs are going to follow this first order kinetics. Again, unless I say otherwise, just assume it's going to be first order kinetics we're going to be talking about here. Okay. So looking at how we can affect this, so looking at renal clearance of medication, this will probably be the most common thing you're going to run into of alterations in renal function, how it's going to affect your drug dosing. Again, looking at this, we can look at the concentration of the drug and also the rate of drug administration. So for instance, when we're looking at clearance, you're just going to equal roughly the rate of drug administration, how much drug I'm actually putting into the system, divided by the drug concentration itself. Okay. Another way we can look at that is basically to convert it, we see that the clearance is equal to the dose that we're giving divided by the interval. When I say interval, what does that mean? Yeah, so am I giving it every 12 hours, am I giving it every 24, every 8, every 6, or am I giving it continuously? That is all going to influence the interval there. So I'm looking at the dose divided by the interval divided by the drug concentration. So you're going to see there's kind of a proportional sort of relationship here with first order kinetics. So as I increase the dose, what do you think it does to the clearance? It's going to go up, right? So again, because that's first order kinetics, the more drug there is in the body, the more it's going to be metabolizing because it's always that same percentage, right? Again, I'll show you a graph and it'll make a little bit more sense there. So anyway, again, this is a proportional relationship between that drug concentration and the amount of drug getting cleared per unit of time. The more drug is in the system, the more it gets eliminated for that period. So looking at an example here, say we're looking at hours here as it goes up. Say I gave a 1,000 milligram dose via IV to the patient, again, it's just some random drug, and you're looking at the amount eliminated, and you're also looking at the fraction that's eliminated for that period of time, right? So again, if I look at the first hour, say I'm getting 15% metabolized for that first hour, okay, I get 150 milligrams of the drug metabolized. If I go to the second hour, what do you notice about the amount eliminated? It's going down, right? Because there's less total drug in the body to interact with those enzymes and whatnot, but it's still 15%. So as the concentration gets lower and lower and lower, you're going to see there's less and less drug being metabolized. Okay. Now, if I was to look at this in say a zero order kinetic sort of drug, what would you notice about the amount eliminated? It would be the same. It'd be 150 every single hour until the drug's gone, essentially, right? So those are the big differences there. And actually what you can find in some drugs, which is kind of interesting, is if you, again, I mentioned most are first order kinetics, if you give enough of some drugs, you can actually overwhelm and saturate those enzymes, and then it converts from first order to zero order. And that extends the half-life dramatically. So a really good example of that, I have the epilepsy drug called phenytoin. We use it very frequently for seizure patients. And so we had a lady who came in, and she complained of seizures, right? So she came in, she got loaded with a dose. She got a big bolus dose of phenytoin, right, to get her levels back up to a normal range. Phenytoin normally would be first order kinetics when it's at normal therapeutic range. Well, there's a change of shift around 7 o'clock. No one got the handoff that the patient had already gotten that bolus dose of medication. So guess what? She got a second bolus dose of medication. This is before we switched over to an EMR system which would have hopefully caught something like that. So anyway, so no one caught it, and the patient didn't know any better, so they, when the nurse came to give him another dose of drug, they just assumed that was normal. Patient got a second dose of the drug, and one of the things you'll see with phenytoin is patients get very, very ataxic, they get very dizzy, a lot of nausea and vomiting symptoms because they're so dizzy, they get a lot of nystagmus. We end up having to admit that patient, who was otherwise going to be able to go home, because of this level. The thing is that because we saturated those enzymes, she switched from first order to zero order, and now the half-life of the drug extended out dramatically. And so we were looking at her having possibly a 3 to 4 hospital day stay just to let her metabolize that drug off due to something we did to the patient, right? That iatrogenic sort of error that happened. There's ways we can get around that, and that's why the tox was consultant. We came in and we were able to get the patient out sooner. However, if you didn't have that around, if you didn't have the wherewithal to fix that, it would have been a big hospital stay. And again, that's expensive. The patient probably didn't bargain on being in the hospital for that long, So again, it's a big problem there. So again, having understanding these kinetics can help you understand what's going on with the patient. All right. Again, just another graph showing you that first order kinetics. Again, as you have a higher amount of drug in the body, get a bigger amount metabolized per that unit of time. Here is just looking at time of half-lives. And again, every half-life you're getting 50% of that drug eliminated, right? So again, as you get smaller and smaller, still getting 50% of the drug eliminated, just happens to be a smaller amount because, again, of that first order kinetics. Okay, so I'm not going to have you calculate things like KE You know, I'm not going to have you do like natural logarithms in your head on a test. That would be kind of mean, right? But it's important to know that this constant means because it's going to inform what our half-life is essentially. And so basically, when we're trying to figure out that fraction of drug, that percent of drug that gets metabolized per unit of time, let's say an hour, that is going to be represented by this value Ke essentially, right? And so I use Ke all the time when I'm doing kinetics for my patients over at Nemours. So again, this is something that we use clinically. And so if you're unlucky enough to not have a pharmacist that does your kinetics for you at the hospital, then you may have to do this yourself potentially, right? It could be something you do. Anyway. Basically, if you're looking at the log of the concentration, so when you're looking at a first order kinetic metabolism, if you were to convert it to the log of concentration, it basically straightens out the line, right? So that's why it looks like a straight line, even though it's first order kinetics. And basically what we do is we actually take this natural logarithm of two levels, a peak and a trough. When I say a peak level, what does that mean? The highest level it gets, and what's a trough? Yeah, the lowest level you're going to get before, say, the next dose, right? So you can do a peak and a trough. So I could do two levels here. I could do this very top level and the very bottom level, or really I could do anything kind of in between, as long as there's two different levels. And I know that difference in time. So again, I want to know that time because that's very important to show me how fast I'm metabolizing that drug. So by getting this value, basically I can understand what this percentage is going to be. So I know per hour, how much should they be metabolizing from a percentage standpoint. The other thing I can do is convert this over to look at Ke actually equals the clearance over the volume distribution, right? So we know, and this makes sense, that if I have a lowered clearance, what do you think that does to that proportion of drug metabolized per hour? Should go down, right? It's in the numerator. So I have less clearance. Guess what? I'm going to have a smaller fraction of that drug being metabolized, okay? If the volume distribution is larger, what would that do to my Ke? I would decrease it as well, right? The denominator is now bigger because the drug is more partitioned out into the tissues. It's not as readily available in the blood to actually be eliminated by the kidneys or the liver or wherever, right? So again, that's also going to make that proportion of drug per hour be metabolized more slowly, okay? So why does this matter? Why do you care about Ke? Because this will directly inform what the half-life is, as we'll see in just a second. So basically, if you look at the half-life, you know, again, it's going to be the time it takes for 50% of that drug to be eliminated. So for instance, if I was looking at, say, a drug concentration, say, of 20 micrograms per ml at 4 p.m., and then let's say I looked at 8 p.m., and the concentration is 10 micrograms per ml, what would you say is the half-life of that drug? 4 to 8 is how long it took to get 50% of the drug eliminated. It is that easy, right? It is pretty straightforward when you're looking at it from that standpoint, right? So 4 hours, 4-hour half-life here. Let's say, for instance, we have a drug concentration of 40 micrograms per ml at 8 a.m., and then we have a concentration of 10 micrograms per ml at 4 p.m. What would be the half-life? Oh, so now the question is, how many half-lives have we had here? So I went from 40 to 20 on the first half-life, and then I went from 20 to 10 on the second half-life, right? So again, less drug being metabolized, but that makes sense based on our first order kinetics knowledge. So she had 2 half-lives, and at what time? What's the time frame here? So from 8 a.m. to 4 p.m. How long is that? 8 hours, right? And again, this is why military time is used in the hospitals, right? Because it's a lot easier if I look between 0800 to 1600. That's why we like military time, because that makes us a lot easier to do. But let's say, for instance, we're using standard 12-hour clocks here. So again, that's 8-hour difference between 8 a.m. to 4 p.m. So okay, so 2 half-lives in 8 hours. So 8 divided by 2. It's still a 4-hour half-life, right? So again, you should be able to do something like this pretty easily on the test. Again, I might have something you know, pretty simple you can do in your head. Again, if I were to have a drug concentration of this at this time, and then I get this concentration at this time, how can you figure out the half-life? And it'll be something pretty round numbers-wise that you can figure out pretty easily. I'm not going to have you do any natural logarithms, as I said, and anything crazy like that, right? Does that make sense for the half-life and then figuring out what the actual? Good. So again, looking at that, if I were to see, 4 hours, I'd get 50% of that drug eliminated, another 4 hours, another 50%, another 4 hours, another 50%, and so on and so forth. So the drug concentrations are negligible. Okay, so why do we care about the half-life? Well, because it can be very variable between drug to drug, right? So we're going to see that things like adenosine, we're familiar with giving adenosine, right? Who's given it before? What happens when you give it?
Well, if it works, it slows down the heart.
I mean, it like stops the heart for a second, right? And if you're looking at your continuous EKG, so we use it for things like supraventricular tachycardias. So you have a patient's like very, very fast heart rate, beating up in the 180s or something. Go ahead and give them the adenosine. You give it fast enough, should stop the heart for a second. Everyone gets really kind of like, and then heartbeat comes back, hopefully, right? So again, hopefully, right? Hopefully it breaks the SVT and they're back in a normal rhythm, right? That's always the goal. But we see the adenosine has a half-life less than 10 seconds. So that means in less than 10 seconds, 50% of the drug's already gone, which is why it's really important that when you administer it, it needs to be given very quickly, right? So if anyone's ever seen adenosine given, you have to make sure you slam it as fast as possible and then flush right behind it with usually 10 mLs of normal saline to get that drug to the heart. Because I'm giving it in a peripheral vein in the arm, I need to get that back from in the venous flow back to the heart as quickly as possible. So frequently what you run into, people will give it inappropriately, give it too slowly, and you'll find that the first dose, they're like, oh, the first dose didn't work. So let me go ahead and double that dose and give it the next time. So now they've doubled the dose. Now there's more drug around. So by the time they give it, it actually does get to the heart and is effective, right? So some people kind of inadvertently have to give more a drug because it wasn't given quickly enough. So that's why we used to have like some kind of like a three-way stopcock sort of thing set up where you have like one syringe with the drug and one syringe with saline, and then you have to push it really fast. But so again, that can be less than 10 seconds. Another drug which you might also use, say for instance, if your adenosine didn't work and they're still in having arrhythmia, you give amiodarone. It's another popular antiarrhythmic that we use in the ER. This has a half-life of 26 to 107 days. Very, very long half-life, right? So you're going to see this can stick around for a very long time. You can actually see some very chronic sort of issues that pop up from this, from just long-term drug deposition. You can see things like skin color changes that can happen from this drug, but it sticks around forever for the most part, right? But even if I go 3 months, I may only have 50% of that drug gone, even if I took just a single dose, right? So when we know the KE, we can actually figure out what the actual half-life is. And again, KE is just that percentage of drug that we be metabolizing per hour per unit of time. And so basically, and again, I'm not going to have you calculate this specifically, but I want you to know is how the variables are going to be affecting half-life. So again, if we know, basically just if we know that half-life is equal to this 0.693 over KE, alternatively, because we know that KE is equal to clearance over VD, I could sub that in and basically get that my half-life is equal to this 0.693, which you don't have to worry about where that comes from. However, what I do want you to note here is that the volume of distribution divided by clearance. Okay, so this means that if I have a higher volume of distribution, what does that do to my half-life? It's going to make it longer, right? So again, the longer the half-life shows me the slower that I'm clearing it from the body, okay? If I have, say, lesser clearance, so my kidney function goes down, my clearance is going down, what happens to half-life? It gets longer, right? So now you can see kind of conceptually why this matters and why that can change the half-life of the drug so significantly, right? So maybe instead of giving a drug every 12 hours, because the clearance has gone down and the half-life is extended, and they only give it every 24 hours, right? We do this pretty frequently. Say we have like a premature neonate. We'll talk about neonates a little bit later. But premature neonates typically have pretty underdeveloped kidneys, and so they can't really handle some of the drugs we give them. And so some of those drugs we may give, say, Q12 hours to some more developed neonates, but then for some of them we have to give every 24, every 36, every 48 hours, just to show you how slowly they're clearing that drug. Still the appropriate dose, we just have to give it less frequently, right? Okay. So again, we kind of talked about this, but the larger volume distribution should extend the half-life. A smaller clearance should also extend the half-life as well. Okay, and then the flip would be opposite. If I had a decrease in volume distribution, that should decrease the half-life. If I had an increase in clearance, that should also decrease the half-life as well, right? So keep those relationships in mind. It's a good thing to know. Okay, so now this is from steady state, I kind of alluded to, and basically this is going to be the point, and I'll show you some graphs to make this a little bit more clear, but it's the point where the amount of drug, so say I'm giving a patient a drug via, say, continuous infusions. I'm giving a very continuous dose to that patient via IV, right? Basically, when the patient gets to a point where the amount of drug being metabolized, say per hour, is equal to the amount of drug that I'm putting into the patient, you will get this steady state level. It's basically this level that the patient will be at, because you've now achieved this equilibrium where they're metabolizing the same amount that I'm putting in per unit of time, and they will stay at that level indefinitely, right? So assuming I keep giving that continuous infusion, nothing change, no parameters change. If I give it forever, the patient will have that level forever, essentially, right, until I change something. So what you're going to find is, and how often do we give continuous infusions versus like giving like oral tablets? Not very frequently, right? It's a kind of intensive, labor-intensive sort of thing to do. Usually, like in your ICU patients, usually the sickest of the sick. However, we give in drugs intermittently. We'll see how we can also reach steady state levels based on kind of average levels that we'll achieve in these patients. So, anyway, what we're looking at, and again, we'll abbreviate steady state as this. The concentration at steady state is CSS. Is basically going to be equal to the dose that we're administering divided by the clearance of the drug times the dosing interval. Okay. So looking at this, you're going to see that, as we know, the clearance is going to be proportionally constant to the amount of drug that we have. We need to equal that with the amount of drug we're putting into the system, okay? So we're going to see how we can modify some of these things to actually change what the steady state concentration is going to be based on these variables here. Because again, as a clinician, what can I control? I can change the dose, right? And what else can I change? I can change the interval. Can I change the patient's clearance? Not unless I hook them up to a dialysis machine, but that's kind of outside of our scope, right? So again, we can change dose, we can change interval. Those are going to be the big things that you can change as a clinician. Okay, So looking at this, our average concentration, keeping these relationships in mind, what effect does dose have on the CSS? So if I gave a bigger dose, what should I do to my steady state concentration? It should increase it, right? Because I'm going to give a bigger dose, I'm getting more drug in the system. Remember, as I'm giving more drug into the system, I'm also metabolizing more of it because I'm still at that first order kinetics, right? What effect does increasing the dosing interval have? So say I went from giving drug every, say, 12 hours to every 24 hours. That would decrease my steady state concentration, right? Because now I'm going to keep everything else the same. I'm giving the drug less frequently. That'll make my denominator bigger. CSS should go down in that case, okay? What effect would, say, changing the clearance do? If I, say, had a decrease in clearance, that would increase the steady state level, right? Because I'm clearing the drug less effectively. The half-life is extending. That level is going to get higher. And it gives us to make more sense when I show you the graphs here. The thing to note is that roughly you need to have 4 to 5 half-lives at a steady dosing interval, steady dose, before you reach steady state. That's a good number to remember. It's about 4 to 5 half-lives before you hit steady state, okay? All right, so again, imagine if I was giving you a continuous infusion. So again, when I hit steady state concentration, this is where input rate equals the elimination rate. So I'm giving a continuous infusion of a drug. Again, you're seeing that as the level is going up, I'm also metabolizing more drug as more is in the body, and eventually you're going to get this plateau. At this point here, this is where you're going to find that the drug is going in at the same rate that's being eliminated, and I reach this kind of steady state sort of level here. And roughly 4 to 5 half-lives is when you're going to achieve that. Okay. Again, I'm not going to go through the math on how to figure that out, but the math has been done. We know that 4 to 5 half-lives is roughly how long it takes there. Okay. So again, if I were to stop that infusion, then what happens to the level? You start to metabolize all that drug and then goes back down to 0. But assuming I were to give that drug again at the same dose, and if I wait another 4 to 5 half-lives, guess what? It would be right there back at the same steady state level. Okay. But again, it's not super common that we're going to do continuous infusions for patients. So instead, what you often do is intermittent dosing, right? So we're going to give dosing at various intervals, right? So for instance, you can still get the same thing, but instead of looking at the actual steady state concentration, you're looking at the average concentration, right? You're looking at the average between the peak level, which we know is the top level you're going to be able to achieve, and the trough level at the very bottom before that next dose you're going to see, okay? So imagine I'm giving, looking at multiples of elimination half-lives. So each one of these is in a half-life here, and you're looking at drug concentration. Imagine I was giving a drug, and you can kind of see how I give one dose, the level gets high, and then it's going to start to be metabolized, and then I give the next dose, okay? Level goes up, and then it starts to get metabolized. Then I give the next dose. And see, every time I give another dose, it's starting to get higher and higher and higher until eventually you're going to hit that steady state level around 4 to 5 half-lives, where now the ratio here between the peak to the trough, that average I'm getting there should be that steady state concentration. It would be the same as if I was giving a continuous infusion, but instead I'm just giving it intermittently, okay? So this is beneficial because I can give the dosing less frequently. I don't have to have the patient hooked up to an IV line 24/7 to get that average concentration. Did you have a question there?
Yes.
Okay.
For the steady state, is it only through IV? Do we also do it for the dose?
Yeah, we'll get steady state concentrations to any sort of dosing. As long as I'm giving a steady dose at a steady interval, you can get a steady state concentration.
What about insulin, long-acting insulin?
Mm-hmm.
Will it be steady state?
Yeah, you'll get a steady state of that as well. Sometimes you'll actually find that drugs will get to a level of essentially 0 before your next dose, and so at that point you don't really get a steady state concentration because you're eliminating all of it before you give the next dose. That wouldn't be the case in insulin necessarily, but certainly, yeah, with any drug, as long as there's still some around in the system before the next dose, you will still get a steady state level, right? It's just you'll find that with like a long-acting insulin, I don't have to give it as frequently. Something like a fast-acting one, that is pretty much eliminated by the time the patient has their next meal or something. But long-acting is meant to stick around for 24 or 36 hours or so. Yeah, go ahead.
Okay, sorry. So let's say someone was drinking alcohol,
Mm.
just like every so often, like, every few drinks per hour or whatever.
Mm-hmm.
So would that, not the blue line, but the red one, would that be like similar, like if they stayed intuitively drunk, but like?
So would it be the same? Question is, what kind of kinetics do we say alcohol followed? Is 0 order kinetic. This is only going to be for things that follow first order kinetics here, right? So if you're looking at some of the 0 order kinetics, at that point you have to make sure that, and again, a rough estimate is a person would metabolize 1 drink per hour, right? Mm-hmm. So theoretically you do the same thing with alcohol, knowing that if you say, for instance, and there's standards for like what a drink is necessary, but basically you could do something where you can get a person up to a level of certain amount of drunkenness, say like up to 100. And then as long as they drink 1 drink per hour, they're still metabolizing roughly 1 drink per hour. You can kind of get the same thing, but it wouldn't be the same technically because that's 0 order kinetics versus first order.
Okay.
Yep.
Thank you.
Yep. You have a question?
Yeah, like something like amiodarone with a long half-life,
Mm-hmm.
would that ever really be go to like a steady state then?
It will be, and I'll show you how we get around that very shortly. Thank you for that segue. Perfect. So anyway, looking at steady state, so again, we mentioned we can modify the dose and we can modify the interval pretty significantly here in order to get the same steady state concentration. So let's look at this. You know, we have time on the x-axis here, we have the concentration of the drug in the system. And so imagine I have 3 different dosing strategies. One is this dark line here is going to be the continuous infusion. And again, when I'm giving a continuous infusion, I don't get an average steady state. That's the steady state level essentially, because there's no vacillation between peak to trough, because I'm always giving the same amount of drug. Okay. Again, not super convenient. We don't do it very frequently. On the other hand, let's say I was going to give a drug, say, for instance, every 8 hours. Okay, so this is going to be this kind of light gray line here. You notice here that you're going to have a peak and a trough level, and a peak and a trough level. But again, after 4 to 5 half-lives, you still should be getting roughly the same average concentration as you would see with the continuous infusion. It's just you're going to have higher peaks and lower troughs. Okay. Now, on the flip side, let's say we're going to give a drug at an even bigger dose, but at a less frequent interval. All right, so we're going to give it less frequently. So in this case, we're giving a drug every 24 hours. So I have to get the same steady state concentration, I have to give a big dose, get a big peak here. I'm going to see a lower trough. So again, the change between peak to trough is going to be larger here. However, it's still going to take the same rough number of half-lives to get the steady state. It's still going to have the same average concentration. You're just going to notice there's larger difference here between peak to trough. So clinically, why might that be important? Yeah, so for instance, if I give a certain dose at a certain time, I know, okay, well, if I'm giving this big of a dose, I want to give every 24 hours, right? So that could be one thing. What else? Perfect. Toxicity is going to be a big thing. Also, efficacy is what we're going to see. So, looking at this, you know, what would happen if you were looking at this dosing strategy and you say, okay, well, this person, my patient, is likely to get toxicity when their levels get above 20 milligrams per liter. So, do you think the Q24-hour dosing strategy is going to be good for them? Not really, because you know that every time they get a dose, they're going to get a toxicity, and then they'll metabolize it off, but then every single dose. So that may not be a good option for them. Maybe if I give a smaller dose, but I give it more frequently, maybe I give a smaller dose every 8 hours, they are now at a level where they don't get the same toxicities, but they still maybe maintain that efficacy, right? On the other side of that, what if I don't want my troughs to get too low? This becomes very important when we're talking about antibiotics and treating different types of infections. So if you imagine some antibiotics you can give every 24 hours, some of them you have to give like every 6 hours, some every 4 hours as the case may be. And so we do that because we'll talk about in the bugs and drugs section in Pharm 1 that there is a minimum inhibitory concentration. There's a level you have to get above in order to prevent the bacteria from replicating, right? So as long as I get above that level and I keep the drug above that level, then you're going to see that I can keep that bacteria from replicating. I can clear the infection, right? So in this case, if I were to give, say, the drug every 24 hours, but let's say the minimum inhibitory concentration, say 5 milligrams per liter, if I give this big dose but only every 24 hours, you can find that you may actually get below that MIC, and now the bacteria can start to replicate.
So how would it be with patients that get prophylactic antibiotic, they get 2,000 milligrams per se of amoxicillin before procedure?
Yeah.
How would that?
So with that's usually like a one-time dose, or maybe just a few doses. And essentially, if you do it like, say, I'm going to the dentist and I need amoxicillin, maybe have like a cardiac history or something, I'm looking to prevent endocarditis, right? That would be a case where you take a big dose right beforehand, so that way the antibiotic levels are high enough to prevent any bacteria from translocating, say, from the mouth into the bloodstream and potentially causing an infection.
That would not be a constant level then?
It depends on the dose, and so if some drugs you're going to find you have a pretty wide therapeutic index. When we talked about that, where I can drive the doses really high, get really high concentrations, and I don't really see much toxicity. Other drugs you couldn't really do that with. So it just depends on the drug. Amoxicillin is pretty benign for the most part versus some other antibiotics, which might, because again, when you're looking at specificity, amoxicillin is very specific for bacteria, not as specific for us, right? It doesn't want to kill our cells off versus like chemotherapy wants to kill cancer cells, but also kill all of our cells as well because it can't tell the difference, right? So anyway, so if I was looking at that example with the MIC is 5, you're going to find that this would not be appropriate to give it every 24 hours because I would drop below that level, and then I would find that the bacteria could replicate. Okay. So again, what's the benefit of giving a drug every 24 hours versus every 8? A lot better for the patients, easier compliance. If I take something 1 time a day versus 3 times a day, it's going to be a lot easier to do it 1 time a day, right? So again, frequently, if you can get away with doing something less frequently, that's going to be better for the patient overall. However, you can find there's certain times where that's not going to be appropriate, right? So again, if I were to give, say, the antibiotic, say, every 8 hours, I can maybe say above that MIC, right? So I'm above that level of 5, and I can continue killing off that bacteria.
And toxicity can also just be like side effects.
We're going to talk about that a little bit later as well. Yeah, so this will include anything from, you know, minor side effects like cough all the way up to angioedema, you know, things like that. So it can, again, have a whole range there for sure.
So like if we were if we know that the toxicity is not, it's like tolerable, then we might run it for more convenient ones.
Yeah, absolutely. So again, it's always a risk-benefit analysis, right? So you're always going to find like, okay, what can the patient tolerate? You know, for instance, you know, there's a drug that the ACE inhibitors, right? It's a common one we use for hypertension. Lisinopril, you know, there's a whole host of them. One of the side effects is a dry cough, right? Dry, hacky cough. And again, maybe the patient doesn't even notice it after a while, but again, you can actually find family members who are like, this drives me crazy. You need to get them off this drug. It is so bad. And so again, even minor things like a cough like can actually be significant enough to get someone off of the drug onto something else, right? So yeah, it can absolutely make the whole range. You know, it could be things like, you know, sexual dysfunction, like, you know, for someone who like, yeah, Zoloft, you know, a lot of antidepressants cause a lot of sexual dysfunction. You know, maybe that makes them even more depressed than they were before they got on the Zoloft, right? So again, those are things where you have to make kind of decisions based on the risk of, you know, them maybe not having their treatment, their depression being treated versus the side effects that are really kind of bothersome to them. For some people, that may not be a big issue. Maybe they didn't want to have sex in the first place, or they're single, or who knows, right? So again, you're always making those kind of adjustments there. Yep. So again, just know there's what we call like kind of fixed dose or fixed interval sort of dosing strategy. This table kind of looks very similar to what we were looking at before, as far as either giving a really big dose less frequently or giving a smaller dose more frequently. You can still get the same average concentration at steady state, right? Again, 4 to 5 half-lives it's going to take to get to that. Okay. And again, if you were to look at that, say just looking at a single fixed dose here, you notice that again all that metabolism is still occurring here, but again by the time you're at a certain point, you're going to give another dose, and so again you keep getting this dose stacking that occurs until basically the metabolism catches up to where the amount you're putting in equals the amount that's being taken out of the system per that period of time. Okay. All right. So how do we? So you mentioned amiodarone, right? So you said, okay, if a half-life's 107 days, it's going to take us 500 days to get to a steady state. Like, how effective is that going to be for our patients, right? Well, we get around that by actually giving a loading dose. And so what you actually notice if you ever give an amiodarone, you're going to have a big dose up front, and then you actually give smaller doses afterwards, usually continuous infusion of amio, in order to keep them at a certain level. And so this is what we do, we call loading doses. We give a much bigger bolus dose up front to get them up to a steady state level, and then you will give them additional medication, usually smaller doses, to keep them at that steady state level. Okay, this is a way to circumvent that 4 to 5 half-lives and just get them at steady state right off the bat. Okay. I'm not going to have you calculate how to do that, but just know that we're going to give basically one big dose up front. So again, imagine this red line is going to be the first dose that I give a medication. It's a really big dose to get that concentration up. As that's getting metabolized, I'm starting off a continuous infusion that will, and again, as one's going up, the other one's going down, so you maintain that same concentration there the whole time, right? So that way I can go ahead and circumvent the 4 to 5 half-lives and get that amio up to the correct concentration very quickly and keep it there, so that way I can prevent, say, my patient from going into VFib again or something like that, right? So again, that's the way we would get around that. Another example is one called lidocaine. We would, in this case, use it as an antiarrhythmic. Usually, it's used as a local anesthetic. Use it in kind of single doses for like laceration repair or something. But as an antiarrhythmic, we give it as a continuous infusion. Basically, what we do is start off with a 1 mg per kilo dose up front. So again, a bigger bolus dose initially as a loading dose, and then you're going to give, say, an infusion where you're doing, say, 20 to 50 micrograms per kilogram per minute, right? So again, there's a big difference between a milligram to 50 micrograms, right? So again, big difference there. But again, you're giving much smaller amounts because they're already at steady state. You can keep them there by doing that, right? Another good, yes, ma'am.
Oh, and you're just saying that like the loading dose will get you through to the, like it'll get you through 4 or 5 half-lives so that you get to the steady state?
It's kind of like taking a shortcut, right?
Okay.
Yeah.
So you're not necessarily going through the half-lives, but you're just taking a shortcut.
Yeah, so again, the patient still has the same half-life essentially, right? But I'm just getting to a point where I give such a big dose up front that the liver's trying to catch up to metabolize all of that, and then as I get that secondary dose going on, that smaller dose, I can go ahead and make sure I'm keeping it there right at that steady state concentration. Another good example, I'm sure most people have heard of like Z-Packs or maybe taken a Z-Pack at some point in their life. If you notice at the dosing, you'll take a double dose the first day, and then you take say 500 the first day, and then 250 on days 2 through 5. That first dose is in order to drive the concentration up in order to be able to kill off those bacteria. Azithromycin has a pretty long half-life, and then those smaller doses keep you at that level to kill the bacteria through your course of say sinusitis or whatever happens to be, right? So again, that's another good example using a loading dose. So anytime you see a big dose given up front and then smaller doses afterwards, that is what we're doing. Is we're trying to circumvent that 4 to 5 half-lives and get to steady state sooner, okay? Because usually that steady state concentration is where the drug's actually being effective, okay? Okay, and then I mentioned after the loading dose, and what we have, what we call the maintenance dose, right? So those are the smaller doses that will happen afterwards. And again, when trying to figure out what the maintenance dose is going to be, we will have to know what our steady state concentration we're shooting for is. And then again, we're going to be looking at the dose, looking at the clearance, and the dosing interval, right? And so again, by looking at this, you can actually rearrange it to figure out what dose you want to use in order to keep it at that level. Again, I'm not going to make you calculate this specifically on the test, but just know how these things are going to be affecting it. So for instance, if I'm trying to figure out my maintenance dose and I were to decrease the clearance, what does that do to my dose? I need to decrease my dose, right? Or if I want a higher concentration, what do I need to do? Increase my dose, right? So again, these are all typically proportional sort of relationships at this point here, right? Okay. All right. Another good example of giving a loading dose and a maintenance dosing. This is a drug called clopidogrel. We will use frequently for patients who are maybe have an MI and they're getting stents placed. It's an antiplatelet drug that helps to prevent clotting from occurring. This is something where you give several higher doses initially to get the loading dose effect and get that level up, and then afterwards you give smaller maintenance doses in order to make sure they keep them at that level there, right? Because again, when you put a stent in, the stent's there, the platelets want to bind to it. You want to make sure you get the antiplatelet effect very quickly. So that's why you give them a big loading dose up front, help them get the antiplatelet effect on board, and then get that stent put in, and then you can give the maintenance doses to keep them at that level to prevent any more platelets from binding to it, right? Because again, if the platelets start binding to that stent, guess what? Have another blockage, have another MI, no good. Okay. So looking at this, given that we know that the CSS equals dose over the clearance times the dosing interval, what do you think could be some reasons why we might have a super therapeutic or too high of a concentration for our patients? So if clearance goes up or down? So if clearance goes up, what should that do to my CSS? It go down, right? So again, if I'm clearing the drug better, then my CSS levels are going to go down. So what would be causes for levels that are too high? Decreased clearance, right? So for instance, one of those things that you run into very frequently with elderly patients is you'll start them on a drug, maybe one that's renally eliminated, and they'll get left on that drug forever at the same dose. And no one ever goes back and looks at the renal function. No one ever goes back and sees that that's still an appropriate dose. I can't tell you how many little old ladies I have coming in from the nursing home. They got started on something like theophylline, which is a super old school drug, but is entirely renally eliminated. They got started on by a doc who probably graduated back in like in the 1800s. And they're on this drug. They probably there's probably a safer drug they could be on, but they've been on for so long. So why change it, right? Why change something that's still working? And they don't go back and reassess the renal function. They come in, their levels are sky high, and now they're seizing, and they've seen some deaths because of things like that. So you have to reassess renal function. You have to reassess organ function over time for these medications, especially like these patients in the nursing homes. They're not being, it's not like they have one-to-one care 24/7. Like oftentimes they can go days without really seeing many people, and they get dehydrated, and that can be another cause for decreased clearance. So those are issues that we run into with some regularity. Okay, so again, that has to do with clearance. If clearance goes down, that could be an issue.
How often should it be reevaluated?
Depends on the drug, right? And depends on the patient. I would say, if it's something that's like really narrow therapeutic, like something like a theophylline, like it's something you want to check more frequently than something that has a very wide therapeutic index, right? So for instance, like a theophylline, that's a really scary drug when you see it in potential overdose. And those are cases where the patient didn't overdose it intentionally. They overdosed because their kidneys just stopped working quite as well over time. They've been building up those levels. So that's a case where maybe every 6 months is appropriate. Maybe every 3 months if the patient's kidneys are really more kind of on a steeper decline. It just really depends on the patient. So in all things in medicine, the answer is usually it depends, right? It's kind of a cop out, but I know students like to have very clear black and white answers. But
Yeah, just want to make sure I understand. So if the clearance in this case is going down, we need to lower the dose for this patient.
Yeah, so it could either be that we will decrease the dose, or what's the other thing that we can affect? Yeah, how often we give it. Absolutely, yeah. So in some cases, changing the dose isn't super appropriate, but maybe changing the interval is, right? Because maybe I need that drug to get up to a certain level, which is achieved by giving that high of a dose, but maybe I can give it less frequently because I know that curve where it's getting eliminated is going to be a lot more shallow, right? So in those cases, and we do that very frequently, like if we're dosing vancomycin for a gram-positive infection, so if someone has like an MRSA infection, if they have a decrease in kidney function, maybe I'll go from giving every 8 hours to every 12 or every 24 hours. I give the same dose, but just less frequently, right? So think about the things that we can modify versus the things that we can't change, right? It's kind of like when you go to AA meetings and you have to accept the things you can't change, and hopefully you have the will to change the things you can. Not from personal experience, that's what I hear from TV. No. Anyway, okay, good. So clearance changing, clearance going down would be one reason for our levels to be supratherapeutic or too high. What else could it be? Could be the dose, right? What if the patient maybe has memory impairment? Maybe they're taking extra doses they weren't, they forgot about, right? So I could get frequent calls to the poison center for stuff like that. That could be an issue. Or maybe, maybe they have an interacting medication that affects the dose and maybe inhibits metabolism, and no one ever went back and addressed that, right? You're going to frequently find, especially if you go into like kind of primary care, family practice, that do patients just come and see you alone? Not frequently. Usually have a lot of specialists, and guess what? When they come in, they have like 3 different specialists that are prescribing medications. Does anyone want to go and change any of the other meds that those patients are on? Never, ever, ever. Because again, it's like that's not my thing. I don't want to get in trouble for changing that med because they'll call me up screaming at me for doing something. And again, people be on medications for years that they don't actually need to be on any longer, or things that are interacting. Patients having side effects, but no one actually will come together, which is why it's so important to have that good like interdisciplinary sort of care. That's why I like working in the hospital because everyone's right there. You can change things immediately. But yeah, out in the real world, like you're going to see that pretty frequently where people don't want to change things. But so again, dose could be an issue here. And then how about the dosing interval? When am I there? Yeah, so if I'm giving it too frequently, right, that could be an issue, right? So maybe the patient's taking it more often than they should, or if they say, for instance, had a case where maybe their clearance was going down and no one addressed that, and they should have been taking it at a longer interval, right? So again, think about how these things can change, and that will change what the steady state concentration is going to be. Same things will happen, but the opposite for subtherapeutic concentration. So if the dose is too low, the clearance is too fast, or the interval is going to be too long, okay? Those can all cause the levels to be too low, as those cases may be. It may not be getting effective, okay? Okay, so other cases where we can see some changes here. So imagine with absorption, right? So imagine with some compliance where, again, if the patient's not taking the drug, of course they're not going to absorb anything, right? So again, if you can give things that are easier, maybe 1 time a day, it's always going to be a lot easier for the patient from a compliance standpoint. Especially with older patients, you're going to find there's a lot of issues with absorption with combating food-drug interactions and other drug-drug interactions. So again, you have, say, older patients, you're worried about their bones, what do you tell them to drink? Don't drink milk, right? So you get a lot of calcium, got some vitamin D in there, but guess what? Calcium binds up a lot of drugs in the GI tract. So again, if I have that interaction where they're taking, say, they have an infection, I'm giving them a fluoroquinolone like Cipro to treat that infection, and then they're drinking it with milk, those bind up, right? We'll learn about that later. Again, it's not important to know the specific examples. We'll talk about those. But if you have it bound up in the GI tract, guess what? It doesn't get absorbed, and guess what? That infection, they'll say they're taking it like they should, and they're telling you the truth, but those levels never get above 0 because, again, they're not getting absorbed, right? So it's, again, really important to educate the patient on this sort of thing, like especially like grapefruit juice, if that's an interaction, milk, other things will bind up drugs, know about that, right? As I mentioned, clearance can greatly affect the metabolism and excretion of a drug, so take those into account, whether it's kidney, liver, heart. This is all factored in when you're looking at your drug dosing references. So again, if you go to look at LexiComp or look at Hippocrates or anything like that, there'll be sections specifically for if you have kidney dysfunction, this is how you need to change the dose. If you have liver dysfunction, this is how you change the dose. And so be mindful of that. Look at those things to see if that applies to your patient or not, okay? Okay, so looking at toxicities, we can see that several different ways for this to occur. So for instance, we can have, say for instance, we have toxicities that occur due to identical receptors, but they're located in, say, different tissues, or maybe by a different effector. So a good example of this is, say, opioid-induced constipation. So when do we take opioids? For pain, right? So again, and that usually is working up in the CNS and the spinal cord to inhibit pain, right? However, do those drugs only go to the CNS directly? Sometimes you could do that. Say, for instance, I did like an epidural, so that a patient who's going into labor, I can deliver those opioids directly to the spinal cord. That's perfect, right? However, not super convenient for most patients. So, but they don't know just to go to the brain. They're going to be going everywhere, right? So again, a very frequent side effect you're going to see with opioids is constipation, because it's going to affect mu receptors, those opioid receptors in the GI tract, just like it does in the brain. So you see it's through the same mechanism. Yes, ma'am. Well, there's no difference between those receptors in the GI tract versus the ones that are up in the CNS. So it's very selective for those mu receptors. However, it doesn't know the difference if it's a GI tract cell or if it's a CNS cell that's affecting, right?
So it's going to be like binding to parasympathetic.
It doesn't have anything to do with parasympathetic necessarily. It all has to do with specifically those opioid receptors. So there just happens to be opioid receptors in the GI tract, and they just happen to slow things down and cause a lot of constipation, right? Yeah, not making the we'll talk about other drugs that can do that when we get into specific examples in Pharm 1 and Pharm 2, but this is specifically just due to opioid receptors there, right? Anyway, in some cases, you may actually find you can have side effects that occur through different types of receptors. So, for instance, there's an antibiotic called erythromycin. Again, not a great antibiotic. We don't use it a lot of times for its antibiotic purposes, as the case may be. However, we do know it interacts with this motilin receptor. And a motilin receptor is something you find in the GI tract. As you might imagine, motilin probably does what to motility? increases it, right? So again, you can see with erythromycin, you see a lot of diarrhea, you see a lot of abdominal cramping because it's interacting with these motilin receptors. In some cases, this is a good thing. We can actually, and we use erythromycin much more frequently for our GI patients to increase motility than we do ever if we're using it as an actual anti-infective. Okay, so in some cases, the toxicities can be a good thing. You guys think of any other instances where toxicities can be a good side effect? Metformin for what?
For people who lose weight.
Yeah, so with metformin, you get a little bit of weight loss associated with that. That could be a good side effect, right?
Is it just because of it could cause diarrhea, or is it
No.
insulin resistance?
No, it has to do with insulin resistance and kind of a GI uptake of glucose and things like that. Again, metformin is a great drug. We'll talk about that later on. But how about anyone familiar with the drug Latisse? Latisse, anyone know what that is originally used for? For glaucoma. It's a glaucoma med, and they realize they're giving this glaucoma med to these patients. Are, man, these lashes are looking like really long and luscious, and like, this is great. Why don't we just market it for that instead? So now there's a cosmetic role for bimatoprost or Latisse that is used specifically for that, and then we still will see it being used for glaucoma, right? So again, sometimes you get positive side effects from some of these drugs. They can be used for other purposes, right? For instance, minoxidil. Anyone know what the brand name for minoxidil is? It's Rogaine. It used to be used as an antihypertensive, and it's kind of a crummy antihypertensive, but they realized when they're giving it to patients, guess what? What do they see? Has hair growth all over. Like, well, just rub it on your head and see if that works. And all of a sudden, now you have a brand new indication for a drug. So again, sometimes these are good things, sometimes not, as the case may be. Now again, think about the toxicities. A lot of times they're going to be mediated through super therapeutic concentrations when the levels get too high. This can either be intentional. So for instance, if I have someone who's abusing medications for a specific purpose, or if they maybe are attempting harm on themselves, that could be one case. I run into that more frequently than not in being in the toxicology world. However, a lot of times it can be unintentional as well. So for instance, little kids get into drugs. Again, they're curious. They grab things and they eat them. I'm actually giving a talk on this weekend. And then there's also things like impaired clearance due to their age. Again, older patients may not be clearing as well. Renal function may be going down. So again, oftentimes these things can be unintentional, as the case may be. Okay, just remember, everything can be poisonous. Even water, even oxygen can all be poisonous. Just depends on the dose. Okay. Okay, as I mentioned, most substances do not have an antidote, so you can't. That's why you need to be so careful with this dosing, because again, a lot of times all we have is a tincture of time to help manage these patients. We have to give the body time to metabolize the drugs out and eliminate them. We can't speed that up necessarily. So again, just think about that before you give a dose. Think, okay, is this the right dose for this patient? Because again, oftentimes once you give it, you can't really take it back for the most part. Okay, so any questions on the kinetics section here? All right, so go ahead and take a 10-minute break. Then we'll start the next section.